Hello everybody, my name is Olga Żmijewska and I'm an emergency consultant in Royal Cornwall Hospital Trust Emergency Department and also the clinical lead for the Emergency Department ultrasound. On today's lecture I will chat about the thoracic ultrasound and its use in emergency department. So what indications do we have for thoracic ultrasound? Well, many of our presentation and patient that arrives to emergency department comes with a shortness of breath. And as we know, shortness of breath can be of various origins. So the patient may have LVF or pulmonary edema, they may have a pneumothorax, pneumonia, pleural effusion, or occasionally it may be due to the pericardial effusion, myocardial infarction, or tamponade. All of those causes can be identified using the thoracic ultrasound. So how do we do it? We can scan the patients when they are sitting up and also when they are in a prone position. When they are lying flat, we have to identify the few lines. First of them is the sternal border, anterior axillary line and posterior axillary line. And we have to also identify the line across the fifth intercostal space and examine the patient in all those four regions. On the model you can see why we do it, and it's because of air and fluid distribution. So patient in the prone position will have the air located in front of their chest, and the pleural effusion or bleeding into the pleural cavity will located at the back. Similar, when they're sitting up, the airspace will be in the apex of the lungs and the fluid will gather at the bottom. So what we are looking for? As you can see here, that's how the normal lungs looks like. So you have the skin, you have the subcutaneous tissue here. Now you have the two rib spaces and it will give us something we call the BAT sign. Because ultrasound does not penetrate through the bone, you have no signal past the bone. So here, when you have those two rib spaces, there is diminish of the signal. Next you have the pleural line and the lung space. You can see those lines, we call them the A lines, and they are the reverberation of the normal pleura. So what we are looking for in a normal lung is to observe the lung sliding, to identify where the pleura is, and if we have A or B lung profile. Now we have to know what A lines are. So A lines are normal for the lung. They are brightly echogenic horizontal lines that are parallel to the pleura, and they are in fact the pleural artifacts, so we call them the reverberation of the pleura. So distance is equal or multiply of the distance between the skin and the pleura. So you can see that here is the pleura, and then you have two A lines in here, and the same in the M mode. So pleura is here, and you can see the corresponds A line below. Now what's the B lines? B lines are vertical lines that arise from the pleura and penetrate till the bottom of the screen. Singular short B lines can be observed in the normal lungs, especially in the posterolateral region. Typical comet-like or laser beam B lines are called excessive, and they are all related to the fluid overload in the lung. And they are often present in the lung parenchyma when there is a decrease of air and increase of the fluid. When B lines are widely spaced, they suggested intralobular septal process, and short spaced suggest pulmonary edema when they come with a smooth pleura, or RDS or COVID when they come with a rough pleura. Here you have the example of the B line in the pulmonary edema. So you can identify the rib spaces. Now you have the pleura and you have the confluent B line arising from the pleura and penetrating to the bottom of the screen. Sometimes we also encounter the E lines, which are B lines, but they are very short and they not arise from the pleura but arise from the chest wall. When examined in the posterolateral spaces, both on the right and on the left, you can see the pleural effusion. So you can see the dome of the diaphragm in here, that's the liver, and that's the pleural space filled with fluid. That's how it looks like. So it's a dark, it's hypoechogenic space that you normally see in any fluid-related presentations. If you look for the lung consolidation, you have to look for something called a PLAPS, so posterolateral alveolar or pleural syndrome. So due to the small percentage of the aerated lung that are involved in the consolidation, you can see lung looking very much like a liver. We call it the hepatization or liverification of the lung, and it is indicated a significant inflammation process. So on the picture here, you can see the dome of the diaphragm, and above it's consolidated lung, so-called the hepatized lung. To assess potential causes of shortness of breath, we use the Blue protocol. So Blue protocol started from assessing the lung sliding, both in the left and the right thoracic. If it's present, and you can see the B profile, so the B lines, it indicates the pulmonary edema. If the lung slide is present and you can see the A profile, you should assess the veins and the heart. If you can see the thrombolized vein, it indicates pulmonary embolism. Free veins with PLAPS point signifies pneumonia. With no PLAPS point, it may be exacerbation of COPD and asthma. Because consolidation obstructs the air entry to the lungs, you may or may not see the lung sliding in severe cases of pneumonia. When lung sliding is abolished and you can see the B profile, it indicates the severe cases of pneumonia. If you see the A lines and you can find the lung point, it indicates pneumothorax. Without the lung point, it still can be a pneumothorax, however, the certainty is smaller. On this video, you can see how the pneumothorax looks like. So we can see the rib shadow, both ribs, and the pleural space in between. You can see the contraction of the muscle itself, but there is no lung sliding on the pleura, which means that the lung and parietal pleura are not touching each other, therefore you cannot see the lung sliding, so-called the Ant march. Now the slide with C before, the example of pulmonary edema. You can see the rib shadow, you can see the lung sliding there, and you can see the profile, the B profile, so you can see the B line coming from the edge of the pleura to the bottom of the screen. So you may ask why we do the lung ultrasound when we have the chest X-ray. Well, look at this table. It shows you that evidence-based practice confirmed that the lung ultrasound is superior to the plain films in diagnosis for pneumothorax, and also, as a recent study shows, in diagnosis of left ventricular failure. If you look at the sensitivity, ultrasound have 86% and chest X-rays 28%, which means you are able to detect pneumothorax in 86 patients out of 100 and only in 28 out of 100. When it comes to specificity, chest X-ray have 100% and ultrasound 97%, which means if you see the pneumothorax on chest X-ray, it's definitely there. If you cannot see the lung slide on the ultrasound, 97% of cases it will be a pneumothorax, and you have 3% when it may be other causes. We all work in emergency department and we know that time is a value. If you look at the time, how much it takes to do the lung ultrasound, it will be average 2 to 4 minutes and you have answer for your questions. When it comes to the chest X-ray, it takes 20 to 30 minutes from the request of the chest X-ray to have it done to report. And that's why we prefer the lung ultrasound. You have another example here. If you look at this chest X-ray, are you able to say if this patient have a cardiac failure or COPD exacerbation? The answer is no. However, if you look at the ultrasound scans, that's the B-line profile typical for the heart failure, and that's the COPD for the lungs and COPD exacerbation. So looking at the lung ultrasound, you have more certainty that you're making the right diagnosis and start the right treatment for your patient. Thank you so much. That will be all about the basic lung ultrasound. I hope you enjoyed the lecture. If you have any further questions, please email me or you can find me on the shop floor and we can scan our patient together.